Here we are with Soloway Speaks. It is Wednesday evening. Wednesday evening, we have an unusual topic that came up this week, and the topic is large vessel vasculitis, and in particular, we're going to focus on aortitis. Aortitis, as the name implies, is inflammation of the aorta. The aorta is the blood vessel that takes the blood from the left side of your heart and pumps it throughout the entire body before it reaches its destination and comes back via the lungs and through the right side of the heart, then back to the lungs, gets some air, and then starts all over again. So what happens if the aorta becomes damaged, inflamed, or diseased? Well, in a hypertensive person, chronic hypertension, often the aorta will become calcified and people will get what is called a AAA, or an abdominal aortic aneurysm. They can get an abdominal aortic dissection, or they can simply have calcific aortic disease. And I want to emphasize that if there is calcium in the lumen, this is on the medial side of the aorta. Okay. Aortitis refers to inflammation of the aorta. This would mean that there's a primary disease involving the aorta. And historically, the aorta would get inflamed on the top part of the aorta where it leaves the heart. This was what was formerly associated with syphilis for the most part. Not that it does not occur, but with the widespread use of antibiotics, both appropriate and inappropriate, seeing syphilitic aortitis is not very common. And frankly, not only is syphilitic aortitis not very common, nor is fungal aortitis. So those are two varieties of diseases which happen to be infections that cause inflammation through infection of the ascending aorta and the aortic arch, which is known as the thoracic aorta. So we have some diseases that actually inflame the entire aorta or inflame the abdominal aorta. So we have the letters AAA, which stands for abdominal aortic aneurysm. We can have IAAA, which stands for inflammatory abdominal aortic aneurysm. So that's one. Inflammatory aortic aneurysm. It's a condition. Another condition would be, hard for me to pronounce this one, Erdheim-Chester disease, which gives inflammation of the entire aorta. And what the idiopathic AAA and Erdheim-Chester disease have in common is that not only do they involve the entire aorta, but they involve the adventitia, which is the outside of the aorta, not the media or the elastic lamina, which is the inner side, and the medium or the middle of the aorta. And when I say the middle, I don't mean the tube where the blood goes. I'm talking about the wall or the thickening, or I should say the spongy or thickness of the aorta. I hope this is making sense. Without slides and demonstrations, it's sometimes a little bit inhibiting. But just know that if there's a coating, or if there's a sheath, or if something forms around the adventitia of the aorta and it is circumferential or circles the aorta, and it involves the entire aorta or the abdominal aorta, you have the two diseases I mentioned, plus you have somewhat of an overlap. There's what is called retroperitoneal fibrosis, and then from retroperitoneal fibrosis, there was a spin-off, and that is the retroperitoneum and abdominal aorta involved with IgG4 related disease. So these conditions have a particular type of pathology: stromiform fibrosis, occasional eosinophils, lymphocytic deposits or lymphoplasmacytic deposits of IgG4 plasma cells. So these are diagnoses that are often made by biopsy. So recently we had a patient come into the local hospital, and unfortunately my team was not called until the patient was in for 9 days. And when we went the next day to see the patient was already transferred to Philadelphia to a tertiary care institution. Unfortunately for the patient, I don't know what their outcome was, because the patient was transferred about an hour before I arrived on the scene. And just based on the findings in the aorta without seeing the patient probably would have responded to high-dose steroids, or in the case of, in the case of Erdheim-Chester disease, interferon gamma would, inhibition of interferon gamma, and there is an interferon gamma inhibitor that's now available, that would be the optimal treatment in that particular condition. These things would have to be diagnosed by biopsy, typically by interventional radiologist, by ultrasound-guided biopsy, or one would hope that the thoracic surgeon would take it upon themselves and get right in and get a biopsy. So, aortitis, large vessel vasculitis. The most common large vessel vasculitic disease is giant cell arteritis or temporal arteritis, and it can involve the aorta as well. Other conditions would be Takayasu's aortitis, which is a large vessel vasculitis in young women, as compared with giant cell arteritis, which is typically large vessel vasculitis of older men. And then there's Behçet syndrome, Cogan syndrome, relapsing polychondritis. These conditions, and Whipple's syndrome, or Whipple's disease, these can have involvement of the aorta. Ehlers-Danlos and Marfan's often have a dilated aortic root, and while they can have a dilated root and they can have aortic valve disease, they don't typically get an inflamed aorta. Damage, yes. Inflammation, no. And I already alluded at the beginning of the primary causes of non-inflammatory are typically related to smoking, obesity, hypertension, where there's simply too much pressure on the wall of the aorta, or in the case of smoking, calcifications inside the media. Anyway, I hope this finds you well, and I hope this answers a couple of questions. And I think the new name of this TV show is going to be called Soloway Speaks. I like that. And thank you to Darlene for giving me that heads up. Nothing to take away from Dr. Monero, who recommended Dr. Steve TV. I like that too. But Soloway Speaks sounds a little political, and this way if I say things that are not fully medicine, maybe I'll get a pass from the people who disagree. Anyway, have a great night. All right, bye.